would like to start with the multiple myeloma treatment goals, and of course it's very important to achieve the disease response, I mean the MRD negativity, and to reduce the active symptom burden. In these days, then we have a lot of novel agents approved and introduced into the market. We have to prevent additional morbidity and to preserve the quality of life of the patient. And of course, it's very important to prolong the patient's progression-free survival and overall survival. And there are a lot of high impact of the novel agents, which we don't have until the 2003, but now these new drugs are approved, and we have a lot of options to treat our patients. But how we can hear from the previously lectures, the number of the autologous stem cell transplantation is still increasing in multiple myeloma. And the proof of transplant in myeloma care from IFM 90 trial and later confirmed by the MRC7 trial was clearly establishing as the standard care of multiple myeloma patients in the front line. Another important finding from the historical data is a value of a deep response. In the achievement of a good remission after induction chemotherapy and after high-dose chemotherapy is very important, because as deeper the remission is here according to the convention criteria, the better is the outcome. And nowadays, like in other hematological malignancies, now myeloma are in such situation when we have a target, the minimal residual disease. And this is the auto-allo transplant, and the achievement of minimal residual disease, maybe it's not, probably is not sufficiently, because here we have MRD mixed patients with the immunofixation negative, but these patients who achieve the sustainable MRD negativity, this group of patients may be claimed as being cured. And what about the autologous transplantation? Here you see the meta-analysis published recently by the Munch. And all studies after the stem cell transplantation, or even not after the stem cell transplantation, they show that the MRD negativity status have clear advantage on the progression-free survival and overall survival. So how can we achieve the MRD negativity? It's several possibilities: that induction chemotherapy, high-dose chemo, and consolidation and maintenance. And I will start from the induction chemotherapy. And if to look from the literature data, adding the second, third, or even fourth agent to the induction chemotherapy, the complete remission rates is going up. What is the best induction regimen? The several clinical trials show that the triple regimen is better than the double regimen, and the now VTD is the standard of care in the most of countries, and the IFM trial showed that superiority of VTD, but in the terms of response, but also it is the cost of the higher toxicity regarding neurotoxicity. And now there are a lot of other novel agents like new proteasome inhibitors and the novel antibodies are introduced into the first line. So maybe after some years we will have another triplets which can be used in the induction chemotherapy. Very shortly about the high-dose chemo. There was a lot of efforts in the past to increase intensity of melphalan 200, but the melphalan 200 still remain the gold standard for the conditioning regimen. And here is the French trial, which try to intensify the regimen melphalan 200 with TBI, they achieved the higher complete remission rate, but was not transmitted into event-free survival. And the same was done by the other trials, Spanish group, but other regimens with the holmium or adding the bortezomib, the results are some promising, but there are no clear recommendation to use these agents as a conditioning regimen. So about consolidation. Consolidation is one of the most discussed issue in nowadays, and the consolidation is the short course of therapy, and it could design it to be intensify the initial therapy, and it could be done by the second transplant, auto or reduced intensity allo. Also, it could be done by the combination of the several agents or by the single agent. In all these studies, you can see that the consolidation, after consolidation, the remission status always increase. So if we use a consolidation, despite what kind of drugs we're using, we can expect the remissions number that it will be increased. Another important finding that after post-transplant consolidations, it was showed by VTD that the molecular remission was increased, and here you see the clinical trial, and then the molecular remission increased until the 18%, and the tumor burden reduced 4 logs. So it was also transmitted that these patients who have the molecular remission, they have also the favor progression-free survival. And here there are 2 randomized trials using VTD and TD as consolidation, and also the Nordic group bortezomib as consolidation. And here is the number of complete remission increased, and also progression-free survival was prolonged. However, it was not transmitted into the overall survival. Other important aspect and the value is the second transplant. The tendon transplantation is very important for the patients who have a high-risk disease. And here I would like to show you one interesting trial. It is a US trial. And the idea was that after high-dose chemotherapy, one arm was without consolidation and other arm with 4 cycles of VRD, and the third arm with second transplant. And all these arms after have maintenance with lenalidomide. And interesting was that there was no significantly difference between the arms in the progression-free survival and overall survival. Also, the progression and the secondary malignancy was the same. But how happened it always in the research? Here you can see the contrast. The other trial, European large trial, more than 1,000 patients were included in this trial, and in this trial was done several randomization. One was high-dose chemo versus non-high dose chemo, and then second randomization was consolidation versus non-consolidation. And opposite the stamina trial, this trial showed that the progression-free survival was favored in the consolidation arm. And also the randomization between 1 and 2 autologous transplantation, you see here, was favored the progression-free survival in the tandem transplantation group. Another approach to do the consolidation is the allogeneic transplantation. It's a reduced intensity allogeneic transplantation, but also here it's not so clear because here you see the Italian group showed that the complete remission rate and event-free survival was benefit in the tandem transplantation group, and also it was confirmed by the BMT retrospective study, but other studies, they did not show such results. And my last slides will be about the maintenance. I will start from the thalidomide maintenance, and here is the meta-analysis, and you can see that the plots are on the left side, so the overall survival has advantage these patients who take maintenance with thalidomide. And recently was another meta-analysis published by the presented by the Etal, and with the lenalidomide maintenance. Lenalidomide is very used in the US and now more and more in Europe. And from this meta-analysis, we can see that the patients have a benefit overall survival if they use the lenalidomide. If to look at the same meta-analysis in the subgroup analysis, we can see that benefit not all is for all groups. If to see the ISS 3 stage of the high-risk patient, they don't have a benefit from the maintenance. So at least at this meta-analysis. So we have to look for other researches. So in conclusion, I would like to say that the achievement of MRD negativity has resulted in impressive long-term survival, and MRD negativity can be achieved with autologous stem cell transplantation in combination with novel agents as induction, consolidation, and maintenance. And maybe the most important message is that the achievement of MRD negativity should be considered in the treatment of multiple myeloma patients if we would like to achieve a long-term freedom from the disease. Thank you for your attention.